Catalyst is which is focusing on accelerating equitable advancements in healthcare, particularly in cancer care, which is one of the main focus, precision medicines, and other critically health-related challenges through innovations, educations, and global collaborations. So in today's webinar series, we will be discussing on precision medicines and challenge and opportunity in advancing global health. And for today, we will have two hosts, which are Dr. Rafaela Casalino and Professor Solomon Rotimi. So before we start, I will kindly ask if Professor Solomon Rotimi can just make a short introduction. Thank you.
Oh, thank you very much, Flair, and I believe Dr. Will is also online. Thank you so much for inviting me. I'm Solomon Rotimi. I'm Professor of Clinical Biochemistry at Covenant University in Nigeria. I am the African Principal Investigator for the Prostate Cancer Transatlantic Consortium, which is the NCI-designated cancer consortium, and also the NPI of the DoD-funded I Care for Black Men Consortium. I've served in previously as the chair of the Aortic Research Committee, Aortic being the Africa Organization for Research and Treatment in Cancer, which is the umbrella body for cancer research and treatment in Africa. And I'm currently the co-chair of the Special Interest Group on Cancer Genomics for that organization. I think I'll just leave it at that for now, and I'm very excited to have been invited to be part of this talk today. Thank you very much.
Thank you very much, Dr. Rotimi. So since Dr. Rafaela is having some late technical issues, so may proceed with your presentations, if that's okay.
Oh, sure. Should I slide? I'll be sharing my slide right away.
Okay.
Okay, so let me know if everything is okay on your end. You see the slide, the presentation. Okay, thanks very much, everyone, and I'm very excited to be here. I've been asked to speak on precision medicine challenges and opportunities in advancing global health, and as I said earlier on, about Covenant University, Nigeria. So just a little bit of background. I think it's nice for us to take a look at what is considered as the determinants of health. In a nutshell, what are the things that when put together makes us to understand what influences our health? And on the outside of that umbrella, as provided by Dark Green and Whitehead in 1993, is what is considered as the social determinant of health, followed by the work environment, the built environment, and then we talk about the way we interact with society and our community, and followed by the individual lifestyle. But at the crux of it is what is considered as the constitutional factors: age, sex, in a nutshell, biology, the genetics, and all of things like that. And following up from that, the WHO also proposed what they consider as the intermediary determinant of health. A very comprehensive, book that they tied to the conceptual framework for actions on social determinant of health. So it may appear as a social determinant of health, which is the focus of what they're talking about. But at the center of it all is what is classified as the biology and behavioral factor. And within this framework, they talk about the concept of embedding, that the social environment sort of have a way of ingraining itself on our DNA. And so the question is, which one comes first? Is it the social environment or the DNA? So several schools of thought have been looking at it that, look, it's all about the environment, it's all about the nurture and all of that. So we continue to ask this question, the nurture or the nature. So yeah, there's a lot of things that we need to really consider about the nature, but more and more evidence continues to come out to show that the nature is very important. So as we consider the nurture, the environment that people live in and all of that, we also cannot discontinue the concept of the biology and the role that the constitutive component, the DNA, plays, particularly how the environment shapes the DNA and how the DNA then turn around to then interact with the environment and influence the phenotype or the disease outcome that we see. And ultimately, how can we take advantage of that to drive clinical care, to drive medicine? And then we begin to talk about precision medicine. And how do we make sure that that serves the entire global community? And so we know that genomic revolution in medicine has transformed healthcare, and that's exactly what is driving precision medicine. Based on a few facts, one is that we're shifting from one-size-fits-all medicine to personalized medicine, to understand the disease at individual level, and then knowing that disease is not abstract, but it can be personalized. And then this is leveraging on advances in disease risk prediction and targeted therapy. So we can look at the DNA, put that in the context of the environment, and really zero in on the precise factors that increases individual or population or group to disease. And then when the disease occurs, how can we take advantage of that component and treat that disease effectively? And these have been applied to cancer, infectious disease, pharmacogenomics, and what have you. So my area of research is in cancer, and I'll be sharing what is very important as the challenge and the opportunities based on what we are doing very shortly. And so it's a growing market globally, and I got this data from Statistica. This is what anybody can look at, and it's interesting. You can see that China and Middle East is really driving the precision medicine market. So the question is, our research is really focused on Africa, and that is where I'm going to pivot to. And the first question I really like to answer is, why Africa? Why are we so much in our own research group focused on Africa? The reason is that, and we can't overflog this. One, Africa is the root of the entire humanity. So when you study genetic variation or genetic component of biology within the African context, you stand a better chance of studying the tree from the root. And so you understand what's going to come up on the fruit. The second component is that we understand that Africa is highly heterogeneous. And I present to you here the human evolutionary tree. So we can classify the entire human population into majorly 5 branches, and one of which, the East African branch, out of that, we then have what we call the Heart of African population. And so majority of the studies that have been done on, people of that we can consider as Heart of African population, such that very limited, in fact, less than 5% about 5 years ago, and it seems the data just keep going down, not because nothing is being done in Africa, but again, the proportion of work that is done out of African population is humongous. And so it's like the entire data is even going down with the, in terms of genetic information that we continue to have in Africa. That's one. Number two, if we're going to make medicine for the future population, can we project down the next 50, 60, 70, 80 years, 100 years down the line? What do we think the demography of the world will look like? The data is clear that as fertility rate is decreasing globally, we don't see that kind of disproportion, huge decrease in Africa. And so the projection, even from the United Nations, is that the sheer population of the world by the next, the year 2100 is going to be 40% Africa because of the birth rate. So the question then is, the workforce of that time, what medicine are we developing for them if we are not really focusing on their genetics as much as we do right now? And those who understand that genetics, we have the ability to develop the medicine and the science that will address the health problem for that future population, which many of us and our children are going to be play some important part of. Okay, and so what is the problem? As I said, few things that are very clear. Over 80% of genomic information are Eurocentric, okay? And lack of data, African data, leads to misdiagnosis and ineffective treatment, even when we try to apply precision medicine to Africa right now. And it's very simple. Before I give you some additional example, we need to understand how drugs are metabolized. If we do not have comprehensive information on pharmacogenomics of African population, and so you can get the drugs approved, you ship it to Africa, and then are we getting, and then lack of clinical trial, oncology clinical trial, for example. And then are we going to get effective response, commensurate response from this population? The answer is obviously there already, and we can see it staring in our face. And so what are the other missing pieces? I've touched on a few ones. So I've talked about a few years ago, I think it was 4 or 5 years ago, that we published this data. And you can read up this publication where we look at the cancer genetics and genomic study in Africa. And you can see clearly the conclusion is simple. We showed evidence that there's lack of inclusivity or representation of African population in genomic, cancer genomics data that is being released so far. Again, you can look at TCGA, for example. You look at whether you have so much information on even African Americans. At that time, you look at TCGA and you're trying to do prostate cancer research. You look at transcriptional data that is there. I think for prostate cancer, you're going to have less than 50, if not even less than 20. I don't have the exact, but I think it was way less than 50 transcriptional data that you have. I'm talking of 50 individuals. And this is for a disease that disproportionately affects Black people. Now, the other question is, why don't we have this data where we look further and we analyze the authorship pattern? Again, our conclusion was very simple. There's lack of capacity, because when you look at authorship paper, Africans, it's very rare to see a core genomics work that was done on African population by African scientists. It's always, people trying to study US population or African American population or Black in other places, and they're looking at reference. They say, oh, let's take some data sample from Africa and let us compare it. Let us use it. Those are the kind of pattern that we saw. And our conclusion was that, look, based on that trend, there was no capacity that was sufficient enough for Africa to address the burden of cancer that African has. So,
sorry, Dr. Solomon, just to let you know that there's 1 minute left.
1 minute?
Yes.
Oh, okay. And so I'll quickly conclude. So what this then results in is that you begin to see where increase in genomic data drive disparity. And so what we have done is that we're doing our best to close this gap. Again, we've profiled prostate cancer genomics, and we identify SNPs that are associated with risk marker in Nigerian population. And then I want to focus on this RS79917, which we consider as a risk marker for Nigerian population, because we're using a wrong reference at that time. But our recent data that we just published and was just accepted last week, we show that SNP that we had called as a risk marker is actually a surrogate, indicator of ancestry, because it's very widespread in Nigerian population. So far, we see it. We have profiled going to close to 1,000 right now. You can clearly see it in up to 90% of the population. And so, well, the good thing is that when you are able to provide this kind of genomic marker, you are able to provide precision therapy for diseases that are hitherto untreated, like castration-resistant prostate cancer. And so putting it all together, precision medicine ages on understanding of disease biology. Studying African population is very important and holds the key. And we should continue to look for opportunity for Africans to lead in solving the African problem. Thank you very much. Please, you can scan my contact and let's keep in touch. Thank you very much.
Thank you very much, Dr. Solomon Rotime. This was a very interesting presentation on which we will definitely discuss in a few minutes. Our second guest has just joined, Dr. Rafael Casolino. So I will appreciate if you could make an introductions and give your presentation. Thank you very much. Dr. Rafaela.
Good morning, good evening, everyone.
Good evening, Dr.
Can
Rafaela.
You hear me?
Yes, we can see you.
Let me pull up my slides. So first of all, thank you really for the opportunity to participate in this great discussion today. And it's a very big honor and privilege for me to be here, and also the opportunity to speak after Professor Solomon Rotimi, who is doing a great work really for advancing cancer genomics and precision medicine in Africa. So now the focus of my presentation will be on the challenges, opportunities in global health, but with a specific focus on cancer. And the premise is that the right to health can be achieved without a universal right to innovation for all. And let's see why. Now, cancer genomics, as Professor Solomon has just said, has the potential to fundamentally change our approach to cancer, with now personalized treatment available for up to 35% of our patients, but we also have personalized cancer detection and prevention. But this is the potential, but we also know that cancer genomics is also exacerbating existing health inequalities, further perpetuating a systemic injustice that prevents equal access to cancer care globally. Now, over the past 2 decades, we saw what we call the precision oncology revolution, which was possible thanks to the progress in DNA technology, sequencing technology, bioinformatics, and also large-scale genomics initiatives like ICGC, TCGA, and others. So now we understand that, and we know that same tumor types from the same histology and from the same anatomic in our body are characterized by different molecular alterations. And this is the basic concept that led the foundation to precision cancer care. Now, the landscape of biomarker-associated therapy is expanding rapidly, both tumor-specific or tumor-agnostic biomarker-based therapy are currently used nowadays for many patients around the world. But when we look at the future, so we will see a tsunami of new biomarkers coming for the routine clinical practice and the treatment of our patients. So the promise of precision oncology is to improve patient outcomes, reduce toxicities, and improve cost effectiveness in the short term, but also reduce the global burden of cancer in the longer term. If this is the promise, we know that the reality is very different. We have barriers at every level, patient level, physician level, infrastructure and technical barriers, health system, regulators, and industry. And the consequence is that access to genome profiling and molecularly guided therapeutic options is currently limited to a very small fraction of lucky patients living in privileged countries. And as Professor Rotimi just said, the issue of lack of data diversity is huge. Basically, everything we know about cancer biology comes from almost completely from European population. And we need data diversity because we need to understand if our therapeutic or preventative strategies work in diverse ethnicities. And when we look at the data landscape, we can see that we are in a complete state of disaggregation now. There is no universal standards for data management and control, and there are major barriers to responsible data sharing, meaning that if different cancer genomics programs from different parts of the world wants to share their data for collaborative projects, this is almost impossible nowadays. And there are also technical limitations of precision oncology, and I don't want to delve into this aspect, but just to mention that we need more data, more real-world data and research data to improve our understanding of this approach. And this approach has many limitations, as I just said. So precision oncology is still imprecise, and this is why we need to include different population, diverse population from different countries and different ethnicities to better study what cancer response to precision treatment is and to track what happens over time. And this is a project that we did in collaboration with Lancet Oncology, where we as International Cancer Genome Consortium present what happened to patients with the same tumor type, with the same molecular alterations, treated with the same therapeutic strategies, but having different therapeutic responses. And then the other main issue is from the clinician perspective, because we want to implement and increase implementation of precision oncology, but the reality is that many clinicians, and particularly those working in non-academic centers, they do not understand genomics. So we need to do more also on the education and training of the cancer workforce. And there are many barriers at the provider level, the complexity of genomic data and the rapid technology advances, and also the educational gap, because many traditional medical education programs also often do not cover the depth of genomics necessary for this application in oncology. Now, if the vision is clear, so to profile and ideally treat every patient based on genomic alterations and to use the genomic data to continue as a continual learning system to improve on our cancer control. We know that the scale investment in time, money, laboratory infrastructure, and workforce that will be required for this to happen cannot be underestimated, as this is huge. And this is particularly important if we live in an unequal world with less funding for health and development. Liquidity is declining, poverty is increasing globally, governance is declining, and the expenditure on healthcare is reduced significantly, meaning that we need to prioritize what is of high value for our patients and highly cost-effective for our systems. In a few words, the current system is sustainable, inefficient, and ethically unacceptable, and needs to be improved significantly. So if these are the challenges and these are the problem statements, what are the solutions? Unfortunately, the solutions are not easy. Complex challenges require complex solutions with local adaptation. And we are trying to understand the complexity of this ecosystem to be able to find solutions for this to be improved. We started a Lancet Oncology Commission in Cancer Genomics and Precision Oncology that is currently analyzing the challenges at the global level of both implementation of precision oncology and those related to data aggregation and data sharing, to provide recommendations to improve delivery of effective, equitable, and sustainable precision cancer care, but also harmonize data collection and enhance data sharing for accelerating research. This is a multi-stakeholder. We are currently working with 45 stakeholders from different countries. No commercial interests are linked to this commission. And we are working through different sections addressing the key priority areas. The current landscape of access to precision oncology, the challenges of implementation, the challenges at a policy level, consideration in low and lower middle income countries, challenges of data process and control, ethics, governance, and legal consideration of data and data sharing, education and training, and we will then propose a future proofing with solutions that can be contextualized based on the available resources, of course, and we will end with recommendations and a call for action. This is work in progress. We aim to launch this commission in 2026, next year. Now, this is what I started when I was doing my PhD with the International Cancer Genome Consortium, but now I'm working at the World Health Organization, and the World Health Organization has prioritized genomics as part of this document published in 2022 from the Science Council, which is called Accelerating Access to Genomics for Global Health. So the colleagues from the science division started a program of work on genomics for health, touching upon different aspects from promotion, implementation, collaboration, and the ethical and legal aspects. And thanks to the work started with the commission, now we are collaborating and integrating information to be able to inform through the Lancet Oncology Commission, also the WHO recommendations on cancer genomics. And this is my last slide, just to conclude saying that systematic implementation on precision oncology bears great potentials, but the status quo is unsustainable, inefficient, and ethically unacceptable. We need to modify this approach, considering focus on equity and inclusion. We need to consider also the economic and financial challenges when we speak about implementation genomics and precision oncology. And we need to always keep in mind the universal health coverage principles, the principles based on which every patient should have access to the healthcare services they need without paying out of pocket from their side. So this means that before implementing tier 3 level interventions and sophisticated technology, we need to ensure that our patients have access to the essential interventions and medicines. This is why I was speaking about a contextualized approach. And then we need to work collaboratively through transparent and cooperation, multi and global sectoral. Thank you for your attention and happy to answer your questions. And if you want to be involved in this project, you can send me an email.
Thank you very much, Dr. Rafaela. This was very great presentations, and Dr. Rotimi, thank you also. So this is very interesting because I was part of a cohort that was trained in South Africa for building precision medicine in Africa and developing precision medicine drugs for African populations, which are part of the low and middle income countries. So one of the questions that I had, because in 2017, the American Association for Cancer Research has the first meeting in Africa, and one of the key collaborative aspects of that came out from this meeting was to create win-win collaboration, because there were not enough African data accessible, because as we all know, most of the data that are available is like the research is mostly done on Caucasian populations and other regions of the world, right? So I would like to know, like, in terms of challenges in implementing precision medicines, what has been the major challenge that you have been facing in implementing it into low and middle income countries? Dr. Rotimi or Dr. Rafaela, any of you can start?
Okay. So yeah, I think I can speak from the Nigerian perspective. So where the question is, one, availability of the lab. So if you want to if you want to test whether a woman with triple negative breast cancer has BRCA mutation that could make her benefit from PARP inhibitor, for example. So, and the woman appears in your clinic, say in Lagos, what do you do? Or say in Yaoundé, what do you do? You ask, oh, do you have the money? And the woman say, yeah, I have the money. So you collect the sample, then you have to ship it somewhere outside of Africa. That's a major barrier. Number two, when the sample comes back and data comes back, and Rafael touched on it very importantly, and ASCO also and mentioned it in their report at some point, that what is the capacity of our physician to even understand and interpret that data? Okay, so that's in two ends. In the middle of it is that data that has been analyzed, what was the reference that was used for it? Okay, that's number three. Because we really don't know the genes that are really pathogenic for African population, we then assume that that gene that has been considered pathogenic, based on data that's available, it should therefore be pathogenic in Africa. And so the solution is the approach that I think we are doing, which is we need to build that capacity locally. We need to begin to strengthen laboratories locally to do the sequencing. Okay, what happens in the case of COVID that you can't send samples out? Okay, so there has to be local capacity to run the thing. And then there must also be local capacity, not just to run the analysis, but to do the end-to-end process completely. Then we must begin to develop mechanism to train the physicians to read or create a system, put a system in place that they can understand and interpret the data in a culturally sensitive way that the patient will benefit maximally from it. I think I'm just talking from our experience of what we're doing and what's been going on.
Okay, thank you. Dr. Rafaela, any comments?
Yeah, I never worked in low and middle income countries, but as WHO, we are assisting many member states globally, and particularly those in lower middle income countries. So if I need to answer from a WHO perspective, the main challenge for implementation of precision oncology is lack of economic resources at the moment. So lack of economic resources to invest in genomics testing, but also to invest in precision oncology drugs. If you look at the list of essential medicines, which is a list of medicines that are highly effective and highly cost effective, unfortunately, only 5 of them are classified as precision oncology medicines. And there are 3 as a class of drug for lung cancer and 1 for leukemia. So this means that the economic issue is really a big one. So this is my personal experience of working when we assist countries implementing their national cancer control strategies. Usually cancer genomics is not a priority. So this is why I said that this is a tier 3 level of intervention, because they want to ensure that the population has, first of all, access to the basic services. But on the other side, this doesn't mean that we shouldn't discuss about it, because otherwise the disparities will continue to increase and the gap will be huge in the future. So let's start with the identification of comprehensive cancer centers, also in low and middle income countries, where at least we can start having a discussion and we can see the results of genomic profiling for maybe research purposes as a first step, and then progressively moving towards implementation.
Okay. I mean, thank you for all these great answers. So I had another comment. So because I remember like while attending that first summit at the conference, and there was one Nigerian researcher based at the University of Chicago. So she took a Yoruba population living in Nigeria, where she profiled triple negative breast cancer patients. And she took another Yoruba population born and raised in America of that very same Nigerian population. And what was interesting is they say that they had very different gene profile. So whether a study will have been done in Nigeria will have been considered as Yoruba specific will not have been true, because those of born and raised in the US did not kind of show the same molecular and genetic signature. And that was very important to me. And that spurred to specific discussions on the creation of biobanking. So I wanted to know, like, from a challenging perspective, like when people establish biobanking, like how do issue like data privacy, ethical concern, and regulatory hurdles can kind of affect precision medicine implementations in general? Yeah.
Hey, thank you, Rafael. So I think I'll pick it up from where Rafael ended, which is strengthening oncology centers to do their own research. As much as we limit shipping of sample outside, I think so many countries will not have problem with biobanking their samples as long as it's done locally. And so the regulatory frameworks are there. Consortium projects like H3 Africa done very well to establish this framework. Okay, so there's no need to recreate the wheel for Africa. Let us grow along. We have not even stretched and tested that enough. We're not doing, we need to do more of the research locally. And then when we get to when we test the limit of the framework we have, I think then we can begin to talk about modifying it. But I think the frameworks are there already in Africa to control, biobanking and data sharing and sample sharing. So I think we just need to do more of the research. So the frameworks are there.
Thank you.
And if I can just add from the ethical and legal perspective, which is a very important question and very timely, we need to balance patient wishes for privacy with the progress of research. Because when we speak about data sharing is very important to advance what we know about cancer, because the more you know from diverse population, the more accurate your information can be. So legal aspects, consent, and everything that protects patients from their sensitive data to be shared inappropriately are essential steps. Then if this is limiting the implementation of precision oncology, I don't think so. Maybe it can slow down the procedures, but it's not limiting it. And we need to also consider that when you look at the system globally, there are challenges now, if particularly in Europe, with the European Data Protection Regulation, GDPR of patients. And this is one of the examples why the legal and regulatory aspects can limit significantly the scientific progress and research.
Okay, thank you very much. So my other question that I had, it was like, I mean, it has like two aspects, like how should like government and policymakers kind of support the development and equitable distribution of precision medicine according to you? And the other thing, and the other question is, if you could recommend one policy change to accelerate precision medicine adoption globally, what will it be, to your opinion?
Well, I think my thought is precision medicine is not all complex. We need to leverage on the advantage of COVID-19. So if you look at during COVID, there are a lot of equipment that moved into Africa. There are places that didn't have PCR that got PCR. Now that not so much is being done about PCR diagnosis of COVID-19, what are those equipment used for? Can we develop, little PCR procedures for profiling genes that are involved in drug metabolism that could help in determining patients that are slow or fast metabolizers? Some of those things can be done by PCR, okay? There are also sequencers that are all over Africa, okay? Now that we are not sequencing COVID, recall that so much sequencing was done in South Africa, for example, that a new variant of COVID was even identified. Now that COVID is no longer there, or we're not focusing on that, why can't we repurpose those equipment and focus on cancer, for example, that is always with us? I think that's kind of policy change that African health system need to really look at, to look at the resources that we have. And by the way, biobanking infrastructures were also set up during COVID. What are we using them for now? All right.
Yeah, if I can add from my perspective, one of the strongest policy recommendations that can be implemented or can be adopted for the implementation of precision oncology and genomic testing is the integration of genomic testing and of course associated cancer treatments into national health benefit packages. Meaning that validated tested for biomarker testing should be included and we need to ensure that they are included in public health insurance programs or national health systems reimbursement policy. But how do we do that? We need to identify, first of all, and prioritize the test with a strong clinical utility and cost effectiveness based on what we know from the literature and for the existing guidelines. This is just the baseline for moving towards broader or more complex technologies, because now we are discussing about individual or single gene testing, but we have comprehensive genome profiling or whole genome sequencing. So we should start again from what is essential strong cost effectiveness, and then progressively move towards more complex technologies. But a patient protection, also financial protection, needs to be considered as the key element here.
This is very interesting. Thank you again to you all. So this is very interesting because in 2026, the South African government launched what they call the Saatchi Chair Initiative, which is a flagship program of the government that was built to that was developed by the Department of Science and Innovations and the National Research Foundations. So that kind of flagship program was made to support national priority sectors. One of them is TB, precision medicines, and genomics, right? And I came from that very center that was created to develop all these precision medicine drugs. We were able to develop like immunotoxins, antibody drug conjugates, and all sorts of targeted therapeutic drugs. And one of the major hurdles, because the idea with it was to produce these specific molecules and then create startups out of these specific like PhD graduates project. But one of the major hurdles is the absence of biomanufacturing facilities in Africa to produce this type of technology. Are there any programs that are implemented to kind of support establishments of this biomanufacturing? Because one thing is to establish precision medicines and having the workforce needed, and another thing is to create the kind of environment safe enough for investors to kind of push that specific type of initiative. Have you ever encountered any projects, collaborative work that are aiming to kind of reinforce that?
I'll pass it on to Rafai because I mean she's in the WHO and she has this global view of what's going on.
Yeah, no, this is a very interesting question. And of course, the capacity building also relies in what you just said, creating local manufacturing, both for technology and for drugs. Now, I think there are several examples of these strategies. Like I can make the example for in India. They are developing there is a very good example this country for implementation of local manufacturing both for technology testing and also development of medicines. But looking more broadly, we need to be careful because this needs to be decided together with the government and with the local authorities, because otherwise the risk is to have biopharmaceutical companies or diagnostic companies investing in this technology and try to sell them. And if this is not aligned with the national health strategy or the cancer programs, then you will have many issues because then you will have the risk that a certain proportion of patients want to have access to expensive testing that are not reimbursed and they need to pay for them out of pocket. So my answer from a global perspective is yes, this is one of the solutions, but this needs to be integrated within a broader discussion within the national cancer control strategies.
Okay, thank you very much. I will turn now to the questions in the chat. So one is asking, what are the initiatives to include all other omics like transcriptomics, photomics, radiomics, etc.?
I don't know if someone you want to answer this question, but from my perspective, this is again a very, very highly sophisticated approach which integrates all the omics, what we call omics, and also digital pathology, artificial intelligence, radiomics, which is happening in high-income countries, academic institutions, but the reality in low-income countries and so on. Maybe you can add your thoughts and reflections here. I think that we are still a bit far away from this to be implemented, but Solomon, what do you think?
Yeah, I agree with you. It's all about funding. And as I responded in the chat box, I mean, our own group, our work also involves doing not just genomics, but proteomics and metabolomics. but that's so much that our fund could cover. If you're bringing in radiomics, then you're bringing in more computing infrastructure to analyze the DICOM data. She talked about the digital pathology data, then you need to bring in more, all those slide scanner. So again, it's all about funding. But it's good that we keep the idea at the front burner. As much as we get opportunity to do it, there is RFA calls that we can apply for funding or collaborative opportunities. Definitely, these are things that we should do. I totally agree with
you. Okay. Thank you. Then I will have another question because I come from a country, Gabon, and what is being done in Gabon, they have a national insurance whereby the Gabonese government funds about 70 to 100,000 US dollar per patient who are diagnosed with cancers. But most of this is kind of compromised to the fact that there are not existing infrastructure. So people then are kind of what they call the medical tourism, where they always have to go overseas to kind of seek the specific treatments. To Dr. Rafaela, I would like to know, like, have you kind of, from a WHO perspective, engaged with governments in order to assist government repurposing that money that is like put into sending people overseas, and how that can be repurposed to better improve infrastructures and maybe deliver more like AI or imaging infrastructure that will enable like to improve treatment?
It is one of the key activities that WHO in our country support. We are supporting governments to understand how to prioritize interventions for the patients with cancer based on the available resources. Because ideally, you would like to provide the best cancer care, the optimal cancer care for all. But when your resources are limited, you really need to decide. And this was a very difficult exercise for me because I come from an high-income country. So when I had to prioritize or to help them, our colleagues prioritize what to include in their national health benefit packages, I struggled very much. But this is the reality. When you don't have enough resources, you need to focus on what is highly effective and highly cost-effective. So we have been developing tools that can assist countries in this prioritization exercise. And we also developed a tool which is called Cancer Priority Setting and Costing Tool to generate an investment case to understand based on the epidemiological burden and what kind of cancer types are those which are high burden in the country. What are the key interventions that need to be implemented, and what is the cost of the investment? But we can also calculate the return of investment. And this is one of the main activities that we are currently doing. Yeah.
Yep. Dr. Rokom, you want to comment, or are there any questions?
No, that's fine. I think there are some questions in the Q&A. My attention just went to there now. So probably we want to go through those questions.
Yes, I've tried to look into the chat.
No,
in
Q&A.
the Q&A. In the Q&A, please.
In the Q&A, I don't see.
Can I read the question? I think
yes, you may, please.
Okay, so first question here is that, Professor Rotimi, what is the greatest challenge for precision oncology in Africa, and where can collaboration help? Well, so Rafael and I already touched on it. One, two important ones to me would be capacity and funding. White people talk a lot about funding, but as an African myself and as someone who work here, I think I want to play down on the funding aspect, but then expatiate more on the capacity. Because even when the money is thrown at it, when there is no capacity, the money is just wasted. But when we develop that capacity include human resource and the infrastructural resource. And the way the role that collaboration can help is that there are places where this capacity, the training can be done. So we need to work together and then begin to look at how we can do training in cancer genomics within Africa. You don't have to go to the US. I mean, I got my training in the US, but we can't continue that way. It's okay for that to continue, US, Europe, and all of that. But we also should be able to do the training locally. Again, infrastructure, I've touched on that. There are infrastructure available. Let's leverage on that. Let's just say, oh, this sequencer was bought for, infectious disease. Okay, let's see how we can use it for cancer. Let's develop bioinformatics pipeline. Most of the bioinformatics training that have been done on infectious disease, and cancer genome is more complex than infectious disease, where you just take a few virus genome or bacterial genome, and then that's easy to do. Cancer is more complex than that. Let's develop capacity, our pipeline to handle that and do things locally. I think that's the area that we can work together. And myself and my group, we're open to collaboration to share our knowledge, our expertise with, any colleagues in Sub-Saharan Africa or across Africa.
Okay. Then the next question is to address to Dr. Casolino. Which region have the least data, and where do you see opportunity to address the disparities in the data?
Well, we just concluded a big landscape analysis of cancer clinical trials in general, but we also looked at biomarker-based trials, which provide not comprehensive, but a large or a broad vision of what is the current situation with data diversity. And we saw that Africa and the small development islands are those with less data represented. So the less data and the less represented in the global landscape of data in cancer. And then where do you see opportunity to address the disparities in data? Again, it's collaboration. And so what's the key message from this webinar today is collaboration, local capacity building, and potentially South-South cooperation as well.
Okay. Then I will go to the next questions, which says, is it possible to generate score that can predict someone's potential to develop cancer depending on their genetics, economics, geographical locations, the food they eat? And then score can also be used to guide their treatment palliative if they develop cancer?
We will get there. We're not there yet.
I think so. I think we'll get there.
We have polygenic
we're not there yet. But it's possible we will get there. But it's a moonshot idea. And I think that's where we're going. And for us to do that, we must be able to then, not just food, we must be able to integrate all of this multi-omics and have it in diverse population. Okay, so we will get there.
And also integrate all this data with the cancer registries and with other kinds. So it is a super, super complex. There is no successful example of such successful example of integration of different data from different registries yet, but we will hopefully get there one day.
And the last question will be
that ties to the one question on AI. So because the data is getting bigger and bigger, that is where AI comes in, because it's getting beyond what you can just do with just simple statistical tools and analysis. So definitely AI is going to play a huge role.
Okay. Then I will have the last questions is, how can those of us in the US audience help in advancing precision medicine? Are there also training programs for those who want to be involved in this area supported by WHO in the LMIC institutions?
Well, Rafael can talk about the WHO program, but I know there are World Bank Center of Excellence that provides training in specific areas that are related to cancer genomics. One of such centers is funded and is located at my university, Covenant University in Nigeria. I think there's another one in Ghana. There's one that focuses on bioinformatics. I think it's somewhere in Kenya or Uganda. These are World Bank funded centers, and they train students from across different countries in Africa. That's what they are supposed to do, and that's what they do. So they have to take students from diverse countries in Africa. So you may want to read on or check on World Bank funded Center of Excellence. It's called African Center of Excellence, ACE. It's scattered all over Sub-Saharan Africa. So you may want to look into those ones that are specifically doing things related to precision medicine. And they offer training at master's and postgraduate level, short courses. And usually when they admit you, you are fully funded and provided some stipend.
Okay, thank you very much. For those who have posted questions, due to in interest of time, you will not be able to necessarily answer this question right now during the webinar. We will make our efforts to kind of address these questions individually. So before we wrap up, as we mentioned at the beginning of this webinar, this is the pre-webinar summit in preparing the Global Health Catalyst Summit that will happen in the coming months in June and in September. And for that, I would like to give Prof. Wilfred Ngwa some minutes to just talk to us about the upcoming the upcoming GHC Summit. The floor is yours, Prof. Will. Is Prof. Wilfred here? No. So yeah, I will just say that there will be a summit this year. You have to know that Global Health Catalyst initiative was created 10 years ago, and this year we are celebrating 10 years of the Global Health Catalyst. So we will be hosting an event in this regard in Harvard University on June the 7th, and further date will be communicated for September in preparing the other GHC catalyst. We have a bi-weekly webinar series, and I think the next topic will be talking on financings. So please join us to learn more about, especially for those who ask questions about micro grants and trainings. You may have an opportunity to know what is available in establishing this training and collaborations, these win-win collaborations amongst Global Health Catalyst and partners. Thank you again, Dr. Solomon Rotami and Dr. Rafaela. I will give you a minute if you have a closure, if you have a word to say before we finish. Thank you.
No, thank you again for this amazing opportunity. And it has been a great honor and privilege for me to be part of this discussion. And again, thank you also to Solomon for joining and for the synergy in this webinar.
Thank you so much, everyone, for having me. Rafael, nice to connect with you again. And thanks so much to Phil and Will for pulling me in here. Thank you very much. I'm happy to be here. And all I just want to say is that, for folks in Africa, let's connect, let's work together, and let's see how we can move the needle forward. Thank you very much.
Okay, thank you very much. Thank you very much also to the attendees who are behind the cameras. It was really a pleasure to exchange with you today, and we look forward to see you in 2 weeks. Thank you. Bye-bye, everyone.
All right, bye-bye. Thank you.